begin. So tranexamic acid. So with hemorrhagic shock, it's a common, frequently treatable cause of death. We deal with bleeding a lot in the ambulances. I'm sure every paramedic on here has been to an MVC, some kind of trauma, even just an accident in the home. We deal with trauma quite a bit. It's actually the leading cause of death in North America, second only to traumatic brain injury. So what this tells us is that in North America, we're very good at hurting ourselves. So it's something that is not new to us. So severe bleeding obviously can come from many different sites. So chest, abdomen, externally, you can basically bleed from anywhere. So tools in our toolbox we have right now, we have the good old gauze direct pressure. We have our tactical tourniquets, depending on where we work. We have those in our region here. We have pelvic binders. So if you have an unstable pelvis and you're worried about bleeding into the pelvic girdle there, we have a pelvic binder. The only thing is that we don't really have too much for internal bleeding. We have IV fluids to help maintain a blood pressure, but if someone has an uncontrolled GI bleed or some kind of interior hemorrhage, we can't really do too much about that. So that's where TXA is going to be a good benefit for us. So before we get into what the medication does, we're going to talk about the trauma triad. Why does this bleeding cause so much problems for our patients? So the first thing we're going to talk about is acidosis. So when patients start having that severe blood loss, they tend to become acidotic. So the reason they become acidotic is because they're losing blood. And if you lose blood, you don't get oxygenated. You go into an acidotic state. Why is this such a big deal? One, it causes tissue damage. Two, it can affect your coagulation factors, and it actually increases the breakdown of clots. So if you have someone that is bleeding out, we want to stop that. So that acidotic state is not good for our patients. The next step here is hypothermia. So as we bleed out, we get colder. That's just a natural process. We lose our body heat through our blood. We're not circulating it through our body anymore because it's coming out of us. So our patients can become hypothermic. So the problem with the hypothermia is this also affects coagulation factors, proteins, platelets, and diminishes our clotting. A big thing to keep in mind with hypothermia, our patients do lose heat due to blood loss, but also just exposure to the environment's a big aspect. It's wintertime, it's not warm out right now. If anybody's ever been to a severe snowmobile accident or MVC in January, these patients are always cold when we get there because they're in shock, they're bleeding out, and the environment's really bad for them. So all of these things really do not help our patients. Another thing to keep in mind with hypothermia as well is just the fact when we do our rapid trauma surveys, cut and exposed, right? So even then they're bleeding out, they've got moisture on their skin, they're getting exposed to the elements because we're assessing them. A lot of things cause hypothermia, and that causes a lot of issues with patients' coagulopathies. The third part of the trauma triangle here is resuscitation-associated coagulopathy. That's a fancy name of saying we're putting too much fluid in these patients. So what happens is, I don't know how long everybody's been EMS here, but I remember back in the day when I was being trained, it was, yep, lots of fluids, let's get their blood pressure up, just pump them full of fluids. The problem with that is it's not blood. We're putting saline or ringers into our patient, and realistically with trauma patients, we should be using ringers. We're going to cause that dilution of the blood. So that's going to affect clotting factors. Also, saline's acidic. Ringers is a bit better. It's acidic compared to blood pH anyways. And that's going to create acidosis as well. So this is going to cause effects on all those clotting factors. And if you can't control the bleed and it's still bleeding out, we're putting lots of fluid in, we're going to flush a lot more blood out. And that's going to cause a lot of problems. So with this trauma triad here, the acidosis, the hypothermia, us putting too much fluid in and causing all these issues, basically with this triad here, it's just going to keep cycling and cycling until our patients eventually die. So we need to do something about that. So what kind of therapy do we have for our trauma triad? The first one is our permissive hypotension. So if you look at CareMap F02, it says it recommends to use a blood pressure between 80 to 90. It's no longer, let's get them back to 120/80 like the textbooks say. We just want to keep enough fluid in the body to maintain tissue perfusion. We don't need to get them back to normal. The reason for that, like I said, we just dilute the blood, we create more acidosis, we don't need to pump lots of fluid in these patients. Which kind of brings us to the next point, avoidance of overuse of crystalloid infusions. So in case you hadn't noticed, we need to watch our fluid intake into these patients. We just want to make sure they're getting perfused appropriately. We want to make sure that we're not overloading them with fluid. Because another thing can happen as well, when you think about our patients, if our patients are really sick, they've lost a lot of blood, their heart rate is decreased because they're cold, they're acidotic, giving all this fluid can cause other problems as well. So just watch your fluids. So obviously we want to reverse the states of hypothermia and acidosis. We want to keep our trauma patients warm. So just getting them out of the environment is huge, right? I'm sure a lot of us can agree we don't like to work when it's minus 30 outside. People don't like being hurt when it's minus 30 outside. We need to get them to a warm environment. So warm packs, crank the heat in the ambulance. When I get on scene for these calls, first thing I do is turn up the heat in the back of the truck. Warm your IV fluids. Even room temperature IV fluid to a trauma patient is cold. So try to give them warm fluids if you're going to give them fluids. Combat that acidosis. The best way to combat the acidosis is stop the bleeding, right? So we need that blood to circulate. We need to maintain that pH in the body. Yes, I'm recording it for the person that just asked. So we want to make sure that we are fighting these. And now in our toolbox, we're going to be adding the addition of tranexamic acid to help with this clotting factors here. So TXA. So the tests on TXA that show us that this is a beneficial medication used for our trauma patients or patients in hemorrhagic shock. A big one here is the CRASH-2 trial. This one was done over 5 years and actually involved over 20,000 patients internationally. This was a huge study that was done over quite a long period of time. So this one showed a reduction in mortality due to hemorrhage of about 1 to 1.5% in trauma-related patients. Now, keep in mind, 1.5% increase in survival does not seem like a huge increase. But when we look at our numbers, just the sheer numbers game, with this is the #1 cause of death in North America, that's a lot of people. So 1.5, even though it may seem small, that's a lot of lives being saved. The big thing with this study, though, is that it showed that the best treatment and the best benefit from giving this medication was if it was given within 3 hours of injury. I know the medication profile no longer has a timeline on it, but basically the study just showed that within 3 hours of the initial injury would be the most beneficial therapeutic time for these patients. Another study I referenced here was the MATTER study. So this one was actually done in Afghanistan at a coalition field hospital. So if war, really the only good thing we get out of war is there's a lot of medical research being done, if there's anything good about it. So they did this study with combat victims here. So this one involved 896 patients with active bleeds due to combat. So these were patients that were brought to the field hospital with some kind of traumatic hemorrhaging. They did make certain factors into effect with patients that came in with head injuries as well. So with this study, it showed a lower mortality for patients given TXA versus patients not given TXA when they arrived at the facility. So with this one, the mortality rate of patients that were given TXA was shown to be 17%. Patients that were not given TXA, they had a 24% mortality rate. So overall, with keeping the head injuries in mind, they found that the overall death rate was reduced by 6.5% with patients given TXA. So again, that's a huge number, especially when we look at the number of trauma victims we have in North America. The nice thing about this trial as well is it agreed very nicely with the other trial there, with the CRASH-2 trial. And both of them agreed that this medication is the most beneficial for our patients if it's given within 3 hours of the initial injury. Whoever's got your microphone on, if you could turn it off, that'd be great. So what does TXA do? So the fibrinolytic system. So this is what breaks down our clots. And this is what TXA is going to affect. But first of all, how do we start clotting? It's good to know how things start. So I am not going to go into the clotting cascade. If anybody's worried about that, this would be much longer than a 30-minute presentation. I'm just going to give you a very brief overview of how a clot is formed here. So basically, you hurt yourself, your body releases clotting factors. That seems pretty straightforward, right? So what happens with that is vasoconstriction limits blood flow and platelets start to form, creating a platelet plug. Okay. So clotting factors like thrombin converts fibrinogen, and then it starts creating the fibrinogen into fibers called fibrin. And this fibrin strands adhere to the plug to form insoluble clots. So these fibrin strands stick to all the platelets in the blood cells that are creating that clot and help maintain that structure of that clot. That is good. That's what we want. That's what's going to help us stop bleeding. The fibrinolytic system, on the other hand, is a system that breaks down clots. So So mostly it attacks the fibrin, begins to break it down. But first, plasma must be converted from plasminogen. So this fibrinolytic system is usually beneficial. We want it. If you cut your finger and your body stops it from bleeding by clotting, we want that clotting to stop. We don't want it going all the way up your finger, up your arm, just creating unending clots. So this is a normal thing. So plasmin is released into the bloodstream, and it is converted to plasminogen, and it's also TPA is released. So the TPA and the plasminogen are released to create plasmin, which helps to break down the clots. So here's a nice little picture here. So as you can see here on the bottom, it has your fibrins. So that's your fibrin matrix that's holding together your clot. Your body has released plasminogen. It has released TPA because it wants to stop that clot from getting any bigger, or it just wants to break it down over time. So on your fibrin matrix there, you have those lysine residues. So as you can see, there's lysine binding sites on your TPA and on your plasminogen. So they come together and they link onto those lysine residue. So once they come together, they bind to that lysine, they create plasmin, and plasmin starts to break down the fibrin matrix of that clot. So that's a natural process. That's what normally would want to happen with our patients with severe hemorrhage. We want to slow this process down. So this is where TXA comes into play. So again, we have those lysine residues on our fibrin matrix on our clot. We have our plasminogen and our TPA. So as you can see, we have those lysine receptors, but now we have TXA floating around. We inserted that into our patient. And what that TXA will actually do, it is an antifibrinolytic, so it'll stop that breakdown of fibrin. So as you can tell here, we have those receptor sites, and TXA will actually block those lysine receptor sites, so that way the TPA and the plasminogen can't combine on the fibrin to create the plasmin. So it'll prevent the breakdown of that fibrin matrix and strengthen the clots. And ideally, that's what we want, because again, if we have someone that's bleeding out a lot, we want as much clotting factors as we can. We want those clots to maintain their structure, and that's where TXA is such a big deal. So TXA in itself, so like I said, here in the Interlake, we're going to be getting this put on our trucks. We're going to be working with the concentrations you see here. It's 500 milligrams per 5 ml. We're going to be getting vials or ampules. I'm still waiting to hear back from a pharmacy about that. So with TXA, it is be given to patients presenting in hemorrhagic shock due to trauma. So again, but if you have the patient with a GI bleed that's uncontrolled, again, look at your time frames. If they're in hemorrhagic shock, we can give this medication to them. It is to be given the IV-IO route within 3 hours of injury or if directed by online medical physician. So again, there is no specific timeline in the care map or the medication profile for TXA, but all the studies are showing it's most beneficial if it's given within the first 3 hours from injury onset. The nice thing about this medication, if you're giving it IV or IO, it is compatible with either salines or ringers. Again, if it's trauma, you should be using ringers, but if you've got saline going, you can give TXA through either fluid. It's also compatible with every patient demographic, pregnant patients, pediatrics. The dose doesn't need to change. It's compatible with all those age groups. So to give this medication, we're going to give a slow bolus of 1 gram delivered over 5 to 10 minutes. So what this means is that because we are using concentration of 500 milligrams per 5 ml, we're going to have to use 2 of these ampules to create 10 mLs. And then we're going to just slowly push it into our IV line. So the reason we want to push it slow is one of the side effects of giving this medication, if it's given too fast, it'll cause hypotension. So we already have patients that are losing fluids or already very sick. We don't want to create more hypotension in these patients by giving this medication too fast. So draw it up in syringe and give, basically it's 1 ml every 30 seconds to a minute. So because this is a slow push, we also have to keep in mind that we don't want to delay our on-scene time. So we don't want to be sitting in the ditch with our patient, starting our IV line, and then sitting there another 10 minutes in the ditch with our sick patient pushing TXA. You have a severely injured patient, this stuff should be done en route. Start your IV en route, start pushing your TXA en route. It's definitely beneficial to our patients, but we don't want to delay them getting to that definitive care at the facility. So most common side effects of TXA, they can cause seizures. Anaphylaxis, just like any other medication, contraindication given it is if they're allergic to it. So if our patients are conscious, we can ask them if you ever had TXA before. If they don't know, they don't know. If they haven't, they haven't. Just be prepared for allergic reactions, just like we would with any other medication that's new to our patient. It can cause headaches, backaches, abdominal pain, nausea, vomiting, diarrhea, as if it wasn't bad enough that they're bleeding out. They now have diarrhea because you gave them meds. And obviously fatigue. So this one's a big one because if your patients are already very injured, they're going to be tired. If they're cold, they're tired. So the fatigue can cause them. You have a patient that's barely conscious, make them even more lethargic. So just something to keep in mind there. So very dangerous but extremely rare side effects of TXA are pulmonary embolism and DVTs. So keep in mind that this is a medication that's designed to hold clots together. So if patients have some kind of increased clotting factors, it can cause clotting issues for these patients. Another one here, this is just it's a temporary thing, but they can have impaired color vision or other visual disturbances. So if you push TXA and all of a sudden your patient's complaining about their vision being disturbed, that's a normal side effect. It is not permanent. The big thing though, like just going back to the clotting factors, if you're worried about pulmonary embolism or DVTs on your patient, you just want to put them on the monitor. If you're ventilating through an eye gel, put on your end-tidal CO2, monitor your ventilator perfusion mismatch, things like that. We want to make sure that we're monitoring these patients just to make sure we're not causing other problems. Again, very rare side effect, but just be aware of it. Okay. So in conclusion, TXA is a safe, very easy medication to use. Basically, if your patient is in hemorrhagic shock or bleeding out, we give them TXA. It decreases the relative risk of death from bleeding by 32% if given within the first hour of injury. That is a huge number. Again, just thinking of the number of people we deal with hemorrhagic shock or trauma, it is a huge number to think about. So it decreases the relative risk of death by bleeding by 21% if it's given within the first 1 to 3 hours. So again, if you can give it as soon as possible, that is ideal for our patients. But like I said, you got extrication, you've got to worry about getting other things going. Try and get it within at least the first 3 hours. It makes a big difference for these patients. And the other beneficial thing about this is that if you do have that delayed on-scene time, it can help with your patient because again, better clotting means less bleeding. So if you have something like someone that's going to be, if you have a mass casualty incident and you've got multiple patients and you're waiting for their ambulance to come in or medevac for even that reason, we can give TXA to help control that bleeding. If you're looking at prolonged extrication times, this will help these patients as well because we want to control that bleeding. That's all I got. So thank you very much. Again, like I said, it's a very short presentation. Just want to get all the information in. So I was just wondering, does anybody have any questions at this time? You can either send it on chat or you can ask.
Hey, Mike.
Hi there.
It's Steph Zoof. Can we use TXA for obstetrical patients postpartum that are hemorrhaging?
So that question was brought up when we discussed the medication profile. It can. The numbers have been shown that it doesn't work exceptionally well, but it is still a treatment option for our patients for sure. So again, that's where the whole hemorrhagic shock comes in. So if your patient is bleeding out due to postpartum hemorrhage, they're going to shock, then absolutely, that would meet the requirements. So a question I got in chat here, I don't know if we can see it. It says, will it be given IV? Does IM also work? So I can actually go back to that slide if you want. So with this here, it'll be given IV. It can be given IV IO, not IM though. We're only giving it IV IO, and it's 1 gram slow pushed over 5 to 10 minutes. From the studies I've read, when it comes to IM, I honestly don't know if it can be given. Every single person was given it through an IV, so I don't know if IM is actually an option for these patients. Any other questions at all? And what do you mean when you ask that? Oh, okay. Epistaxic, yeah, and this is another nice thing. Yeah, thank you for correcting that. I was like, what? So a question was asked about epistaxis. Yes, because again, hemorrhagic shock, right? So if they're bleeding out and they are having an effect from that, then yes, you can use it for epistaxis. The big focus on this medication when they did all the trials was on trauma patients. But that's what I was saying, that when it comes to GI bleeds, like any type of internal bleed, we were really kind of limited in our therapy. And that's what's really nice about getting the TXA on board. So if you do have your patient with severe epistaxis, yeah, blood loss is blood loss. If they're going to shock from losing blood, absolutely, you can give them TXA. And just like any other medication, if you're not 100% sure, if you're like, well, this patient's been bleeding all night, that's greater than the 3 hours they mentioned in the presentation there, you can always call online medical support and ask them for their recommendation, because again, past 3 hours, it may not work as beneficially. So if you are looking past 3 hours, it wouldn't hurt to look for that support if you're not sure. So I got 2 questions at once there. I was just reading them. So are there any issues with TBI, so long term? So they did do studies on head injuries. So there was concerns with traumatic brain injury. For what we're using it for, it was deemed that the percentages were low. So more so with the traumatic brain injuries is usually they'll follow up with a TXA infusion in the hospitals. That's where they were starting to see issues. So us giving 1 gram in the field, the side effects and the downside of that was very minimal compared to the ongoing infusions in the hospitals. So we're safe with that's we took that out because the numbers just, it was more beneficial than harmful. That's a good question. I feel like there was another question there. Is there any other questions at all? Okay, so TXA packing in nosebleeds instead of IV admin. As of right now, I'm not going to say that wouldn't be a good thing, but that's not an option we have for therapy. We're just sticking it straight with IV IO administration at this time. But that's something we can definitely look into in the future. Any other questions at all? Cost of drug? That is a good question. I honestly did not look at costs. I contacted pharmacy and said, hey, can we get this medication on the truck? And they're like, hey, we can get it for you. So we're putting it on the truck. I honestly don't know. I can look that up and get back to you, though, if you'd like to know. I can email it to you. These are good questions. Any more?
In a trauma patient, is it ever too late to administer if they're in shock? Like, how far gone can they be?
Sorry, it was really quiet. So you're asking if it's too late to give it. So like I said, if it's been past 3 hours, the study showed that it's probably not as beneficial. So it doesn't mean it's not going to work. They just found it didn't really work as effectively. So if your patient was in a car accident yesterday and now they're bleeding, that's a judgment call. Very rare we're going to be dealing with severe hemorrhage for someone that's been that long, because if they've been hemorrhaging since last night, they're probably going to be dead by the time we get there in the morning. But after 3 hours, it may not be beneficial. So I'd strongly recommend that if it's been past 3 hours, maybe call online medical support and see what they say. So that would play into the epistaxis question as well, because again, we have these patients that sometimes they sit there all night just trying to control their bleed, for the last 4 hours, and they can't, so they call us. So yeah, so after 3 hours may not be beneficial, but you can still call online medical support and get their opinion on it. Another question here says, does TXA still work with patient with a history of hemophilia? It does, because again, it is actually beneficial. They don't have the normal clotting factors that most people do, so they would actually benefit more from getting TXA. It'll work with what they have, because basically whatever clots they can form, it'll stop the breakdown of the clots, and for them that's even more important. So it still will work. It may not just work as quickly or as effectively, because if they just don't have clotting factors to start with, because basically the TXA just helps maintain clots that are formed, so they have to form those clots first. But at least in the long run, it'll help them maintain those clots that they do form. In case anybody's wondering, here's all the references. I like this. Any other questions though? All right, so I'm not hearing any other questions there. So thank you all very much for being here. I did record this session here. I'm actually just going to stop the recording.